How's it going, guys? Vascular for 2CK IM surgery, family medicine. If you're studying for step one, relax. Okay, you'll have to ace 2CK eventually. I'll tell you some high points here. 59-year-old woman, she's got intermittent claudication, exertion causing pain in the buttocks, thighs due to atherosclerosis peripherally. Okay, so it's essentially angina, but of the legs. Okay, so increased oxygen demand, and then there's going to be ischemia. Causing adenosine formation, breakdown of ATP, and adenosine can cause pain. So 15-year history, type 2 diabetes mellitus, smoking, those are your risk factors for atherosclerosis. Which the following next step management? Should I say angiography? Wrong fucking answer. Never seen this as a correct answer for anything on USMLE for peripheral vascular disease, for carotid stenosis. Okay, you say, well, why couldn't we do it? I agree. I mean, in theory, could be done if we're doing further diagnostic studies, determine degree of occlusion, location, etc. Just always seen it as a wrong answer on USMLE. Wrong fucking answer. Choice B, ABI is correct answer. So you're going to compare the blood pressure in the leg to the blood pressure in the arm. And if the ratio is under 0.9, that's your first diagnostic step for peripheral vascular disease, where because of atherosclerosis in the vessels of the legs, we're going to have a diminution, a reduction of the blood pressure in the legs in comparison to the arm. So this is an extremely buzzy, ultra high yield, ultra pass level first step for peripheral vascular disease on step 2 and 3. And after you do the ABIs, which are decreased, so if they give you a big fucking paragraph, they say in the last line, ABIs are 0.6, what's the next best step? If it's listed, you're going to choose exercise stress test to determine the patient's exercise tolerance. If it's not listed, you're going to go straight to recommend/prescribe a walking/exercise program. About 50% of the time, they'll ask for the stress test. About 50% of the time, they'll go straight to the walking/exercise program. They're not going to list both at the same time. Angiography, always fucking wrong. Cilostazol, always fucking wrong. Okay? So cilostazol is a phosphodiesterase inhibitor, causes peripheral vasodilation, and it has utility in patients with peripheral vascular disease who are already on a walking/exercise program. So it can be very exceedingly rarely correct if they tell you patient has reduced ABIs, is already on a walking program, and then they say which the following agents could help reduce pain / help further mitigate symptomatology in this patient, and cilostazol can be listed as correct, but I say it's wrong pretty much always, because what students will do is they'll get the ABIs are low, and they'll say which the following is the next best step management, and they'll choose cilostazol over the walking program. Okay, so wrong fucking answer. Choice D, exercise echo stress test, wrong fucking answer. So this is when you're looking for heart failure, especially left heart failure, decreased ejection fraction should be 55 to 70. So a patient might have not pain, but might have shortness of breath with exertion. Let's say dude walks up a flight of stairs, gets shortness of breath, has not had chest pain, and you say, okay, they're not specifically talking about ischemic heart disease with atherosclerosis and angina pectoris here. That's not what they're giving. They're giving me left heart failure that is symptomatically brought out. It becomes clinical when the patient has increased oxygen demand in the myocardium. So at rest, maybe the ejection fraction is 60, it's in the normal range, but then with exertion, we have decompensation and ejection fraction falls. So if we do an exercise echo stress test, we'll be able to see the reduction in ejection fraction with exertion. This can also be an answer if a patient needs a stress test in general and has an abnormal baseline ECG. Okay, I just put out a PowerPoint presentation talking about stress tests more specifically, but you can't do an ECG stress test in patients who have abnormal baseline ECGs. Point is, wrong fucking answer. Choice E, ultrasonography, wrong fucking answer. Okay, so this is going to be the answer for the first step in diagnosis of venous disease on USMLE. Okay, so they can tell you varicosities, varicose veins. That's one presentation. They can give you a scenario where there's no varicose veins, but a patient has brawny edema, so hemosiderin laden, darkened, so pigmented calves. So that's increased hydrostatic pressure in the veins from valvular incompetence, leading to the extravasation of the hemosiderin. And so they just like ultrasonography, duplex ultrasonography as a first step. 1 out of 15 times it can be correct for arterial disease if ABIs aren't listed. Okay, I say that because if I don't mention it, eventually, 6 months from now, a year from now, there's going to be someone who DMs me with a screenshot saying, oh, you said ABIs are what we do first for arterial disease, but this one's ultrasonography. 14 out of 15 times, it's going to be ABIs. It's the high yield, buzzy, pass level answer. If they don't list ABIs, you're like, what the hell? Where are ABIs? They can have ultrasonography as an answer. But as I said, angiography is wrong, Slostal is wrong. Ultrasonography, wrong fucking answer. You know the deal. I'm to make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.